we have a discussion, and it has to be a one-to-one discussion as well. Once I conclude my presentation, it will take about 40 minutes of presentation, and after that, the forum will be open for any kind of further discussions with me. So with this note, I would like to share my screen, and let's begin with the presentation.
Yes.
I hope the screen is visible to everybody.
Yes, ma'am.
So, a warm good morning to everyone. As after a very elaborative introduction, uh, am I audible, Razvi ma'am?
Yes, ma'am, you are audible.
Okay, okay. So, as a very dominated introduction given by Madam, I'm very overwhelmed that I will be giving you my thought on this particular topic: the price of well-being, navigating the economics of healthcare access and affordability. Over the next hour, we will be unpacking why healthcare costs matters for individuals and societies, what drives those costs, and what practical pathways exist to make care more possible, accessible, and affordable. So, with this note, I will transit to the next slide. So, very importantly, why we are talking about healthcare economics now, why this topic is very trendy. Because health is both a right and an economic input. When people are healthier, they are more productive. Children learn better, and governments can invest everywhere else. Yet, at the same time, the delivery of healthcare is increasingly shaped by markets, technology, and cost pressures. Globally, healthcare spending is rising, and India is no exception. There is a tension: the ethical argument that everyone should have a basic care, and the financial reality that care costs money and competes with other public priorities. To make sense of those solutions, we must be clear first about what does the well-being means. In this slide, you will get to know the proper meaning of well-being. Well, we all know well-being means more than absence of illness. It includes mental health, social belonging, and economic security. Healthcare contributes directly to several of these dimensions, like prevention, treatment, rehabilitation, and long-term management. So, when we are designing those systems, are we paying for healthcare only, or are we paying for the human capital as well? Now, I would like to make you know the economic building blocks of healthcare. Market is imperfect in nature. In economics, we have a term known as perfect competition. But we know that every market is imperfect in nature, so as the health market. Supply and demand are the two driving forces of any market. In healthcare, also, supply involves infrastructure, technology, medicines, and the workforce. And on the demand side, we have population aging, we have rising disease burden, and we also have changing customer expectations. But we also do not forget that these features, that there are two big features within it. The first is asymmetric information. The patients rarely know about what they need. And the concentrated market power, on the other hand, that means the specialized centers, the hospitals are the two different tales of a different scale. These features often push prices higher and cause inefficiencies. So, in that way, different countries solve these trade-offs differently, and that and what matters here is the cost. Hence, cost blossoms after we get into the economics of healthcare market. Let me go to the next slide. This slide shows the connection of the building blocks we have seen. What we have seen in the previous slide is a demand and supply interaction with policy choices. And now I will be telling you about the global healthcare models. We all know that we have a beverage model, that is the UK based healthcare model, which are tax funded and universal in nature. We also have heard about the Bismarck model, which is a Germany-based model, the healthcare model that uses compulsory social insurance. In Canada, they have a policy of public insurance with private providers. The US is mostly the market-driven health. They mostly opine into the healthcare model, which is market-driven. But India, it sits between the models, a mixed architecture with large private provision and emergent public insurance. Each model has a trade-off. Uh, each model has a trade-off between the equity, the cost containment, and the choice. Equity, cost containment, and choice is the basis of every model in India what we have. So, uh, what now I would like to show you the focus of Indian market. In India's public health spending remains low as a share of GDP. Private expenditure still dominates in India. This slide is showing you the public spend and the high share of out of pocket spending. That structure creates vulnerability. The households can be pushed into poverty by a health shock. Schemes like Ayushman Bharat and ESICs are important steps, but implementation and coverage gaps remains, especially in rural areas. Hence, two central policy problems emerges here. One is access and the other one is affordability. So the next concept will be access and affordability. Access is about whether the services exist where people are, but affordability speaks about whether the people can pay for them without catastrophic consequences. As we all know, catastrophic means the financial disaster, the disastrous financial sink. Hence, for example, you have a physical access, like you have a clinic hereby, but you don't have that financial access like insurance or cost to bear those accesses. So hence, social access is another concept where it includes gender and caste determinants, which are the three important factors that rely on affordability. Policies must aim to close all these three dimensions. Which matters more when designing a program? If this is the question, if whether proximity or the cost, according to my ideology, both should be ideally correct. We also need proximity as well as we need cost. We also need access as well as we need affordability. Then I will be surprisingly showing you the prices of medicines. In this slide, the pharmaceutical industry plays a very major role as a cost driver. Marketing and branding often pushes the higher prices for branded products, even when generics are available. I think many of you must be knowing about generic medicine, that is the Jan Ausadi. India has a regulatory pricing mechanism and the National Pharmaceutical Pricing Authority framework, but affordability remains a challenge for many essential medicines. We must encourage generic prescriptions and rational use as our immediate levers. I mean, for me, if we have a mechanism of generosity, we should actually go for such campaigns. So prices is one of the most important factor when we talk about healthcare cost. Moving to the very basic slide which I am going to show you right now is the healthcare inequality. Inequalities shows up across states. We have regional disparity, we have income access gaps, and we also have social inequalities like educations and environments. So inequalities are is not a factor. Inequalities is the major driving force when it comes to healthcare, whether it is Kerala versus Vimararu states, whether it is within household, whether it is differences in education, differences in environment, differences in employment create health differentials. Because when someone needs a hospital, we think about these inequalities. Hence, financing and insurance are very critical when we are bridging these gaps. We in this slide I am showing you the very basic fundamental of insurance and in financing. uh, when we talk about insurance and financing, I think it goes hand in hand. Insurance can pool risk, but insurance designs determine whether it really protects your household. And government schemes expand coverages but face network accuracy and claims processing issues. And as far as my observations, as far as my understanding, we have government schemes. I think in the before to 2024, in Odisha, I would like to say in Odisha, we have a health card that is on the name of Biju Swasthya Kalyan Yojana, which is now undermined into another card after the change of the government. But we also have PMBJA, JAY, we have other health insurance. We have the best example, I would say, is Ayushman Bharat. So we have government schemes. But private insurances are certain insurances which are actually very cost bearing, but government, as it works under government schemes, it gives provisions for every individual. So for better way for bridging those gaps, for a mixture of public versus private, will actually pull up a lot of insurance and financing models there. So for me, we need to expand preventive coverage and outpatient coverage, and also we need awareness on those particular insurances or government schemes available. So now I will be taking to the emerging trends and opportunities. uh, yes, we do have a lot of trends and opportunities when we talk about healthcare cost. For me, I have in this slide I have shown you four of the major outbound thing I would like to tell here. Talking about digital and telemedicine platforms that lowers access costs. We also have e-Sanjeevani, that is the best example at scale. We have also AI and health tech adoption that improves the diagnostic and triage. We also that also actually lower the cost and avoid over medicalization. And we have a very fundamental part that is the PPP mode. PPP, as we all know, it's public-private partnership models that can that can bring the capacity and can, but also needs to be governed well. So hence, we all have a lot of trends that are emerging, and the opportunities are blossoming very widely in healthcare cost. And but One thing, we need to ensure data privacy and equitable deployment. These are the two major key takeaways of this particular trends, that how we can actually provide privacy of the patient's data, and how equitable we can deploy this particular mechanisms across globe. I will not tell it is across the country. I will rather say it is across globe, because why we cannot access the doctors or the professionals who are in foreign. We should actually encourage those platforms digitally in the method of AI and telemedicine. So equitable deployment and data privacy are two concerned and two emerging opportunities that actually upholds the entire health market. Moving to the very important slide, that is the policy takeaways, policy paths. The first is a strong policy package focuses on universal health coverage. We all know UHC is one of the most important fundamental rights has been given to every individual residing as a citizen, that universal health coverage should be given to each and every individual who needs it. Hence, that will be bolstering your primary care and preventive services and encouraging generics and price transparency. So here I would like to say that universal health coverage gives you primary care, it can give you preventive services, and it can also give you the price transparency, which is actually needed when a patient visits the hospital. Financing must be suitable, yes, of course, because financing is one of the most sustainable factor when it comes to household expenditure, and it could be greater if public investment is incorporated in that particular matter. So better pooling can happen, and efficient procurement can also happen. So with this note, let me give you a very brief, case study that will actually help you understand the entire presentation that I'm going to give, that I have already given. So now I will be bridging the theory to life into two short, concrete stories. One story will be showing you the problem clearly, and the other one will be illustrating the practical solution. So, the first, let's consider a composite but realistic case that reflects many household experiences. For example, imagine a 55-year-old farmer. He has type 2 diabetes and hypertension. His nearest primary healthcare center is 20 kilometers away from his house, and it lacks functioning laboratory. Over a period of months, his condition deteriorated until he needs hospitalization for an infection. Because he does not have comprehensive insurance and must buy branded medicines at the private pharmacy, his out of pocket payment for a single episode wiped out a large fraction of his family's saving. This family is now forced to cut back on fooding and schooling expenses to pay those bills. What does this story highlights? Now, it highlighted several things. The first one is the interaction between poor primary healthcare and expensive secondary healthcare. The second one is how medicine pricing and lack of outpatient coverage translate quickly into catastrophic household expense. And third, the social ripple effect: education, nutrition, and long-term livelihood losses. These are not isolated incidents. Rather, I would rather take it as a common pattern in as a mixed health system. In this particular case, let us now contrast this case to a solution based case. Consider a district clinic network that combines three elements: a strengthened primary care team, a telemedicine link to a tertiary hospital, and a procurement policy prioritizing generic procurement and a state-managed drug distribution. With the similar patient presenting with early complications, a primary care clinician could go to an initial assessment, connect the patient via teleconsultation with an endocrinologist for an adjusted regimen, and prescribe generics available at subsidized cost through the clinic. If referral was needed, the patient was enrolled under the government insurance gateway to cover those inpatient uh, costs. The result is faster clinical response, far lower out of pocket spending, and a much smaller disruption to the family's finances. Importantly, telemedicine actually reduced the travel cost and the time. The generic substitution lowered the medicine bill. Insurance and better referral pathways reduce the catastrophic exposure. So, from these two short stories, what I narrated, we can draw three practical lessons. The first one is invest in primary healthcare and ensure it is connected to higher centers. That limits expensive downstream care. Second, create procurement and prescribing initiatives for generics and rational use. That lowers the medicine bills quickly. Third, it will combine risk pooling. Risk pooling here means insurance with better outpatient coverage and digital drainage. Together, these will reduce the profitability and the impact of catastrophic spending. Now, what are the key takeaways? Very basically, when we talk about takeaways, the final three takeaways, what my understanding talks about is first is your healthcare is an investment in human capital. It is not just an expense, rather, it is a formation of human capital, a better human capital in the next generation. Second, I would say to secure affordability, we must combine strengthened public provision, smarter financing, and a push for generics and rational use. Yes, there must be a balance between two. Whether we are talking about accessibility, whether we are talking about affordability, whether we are talking about the balance between two, that is sustainability. It has to be on a spot on basis. It cannot be on a basis of one on upon another, rather it should be one on one. So the balance of access, affordability, and sustainability, including public intervention, will be smarter enough to balance this cost. And the third one, I must say, it is the technology, the policy, and its innovation. From telemedicine to better procurement, these can lower the cost, but must be designed to expand equity, must design to expand the equitable resources rather than breaching the gap. We need to breach the gap rather than we need to define it into a different terms. So very precisely, if you remember one sentence from this particular presentation, the price of well-being is not only the money, it is the policies and systems what we choose. So we need to be subjugated, we need to be understanding the need of such kind of policies or such kind of importance from this topic, that well-being is not about it's not about money, it's not about finance, rather it is about the mental well-being, it rather social well-being and physical well-being as well. So we need to process the action between healthcare, economics of accessibility, healthcare economics of affordability. We need to align our society from on one-to-one basis, and we need to understand the system what we are choosing before uh, complaining. We need to understand what we have. So hence what we have, we need to understand that first rather than getting into something which we are unaware of. So I think I have given a very vast understanding about the topic given today, and I hope I have given ample respect or obligation to this particular topic. And so I conclude my presentation here. And if we have any questions, we can. I'm I'm ready to acknowledge those questions.
Thank you so much, ma'am. Participants, the floor is now open for Q&A. We can have few questions, open discussion on the topic. You can unmute yourself and ask to ma'am, or you can type your question in chat box. Ma'am, there is one question in chat box.
Yes. I just got the question. Okay. Uh, yes. You are absolutely right. When we talk about investing in health, it's obvious that we have schemes, right? We obviously have schemes like life insurance. We have schemes like health insurance, like Mediclaim is one of the schemes there, as far as I remember. Yes, but there is a distinction. Life insurance, when we talk about those insurances, it is financial protection to your family after you passes away. Health insurance covers the part of your treatment if you fall ill. These are important tools, but they don't solve the bigger structural questions, sir. When we talk about what if hospitals are too far away, what if essential medicines are overpriced, what if questions like preventive cares is missing, so people get sick more often. So when we talk about investment in health, I mean public policies that strengthen the system, better primary health care, affordable generic medicines, vaccination drives, risk pooling schemes. This is what I want to say. Whatever you are saying is correct, absolutely correct. But my point of discussion rests upon these factors. I hope I have answered your first question, and you have a second question, I guess. Okay, the question is, what is the new thing we can add in our life being in investment? Uh, when we think of investment in health, we usually picturize uh, insurance policies or government spending. But if you ask about my personal investment perspective, there are many things like preventive healthcare checkups. We can go for that. We can go for wellness savings. We can go for health literacy camps, workplace and lifestyle choices. These are there. So it's not about instead of talking about only insurance, awareness is one of the most important topic I would like to highlight here. So that's what my perspective will be. I hope, Afsar Ali sir, I have answered your question.
Thank you, ma'am. Thank you. It was really nice explanation. Uh, uh, this is what I was actually supposed to discuss. Thank you so much, ma'am.
Thank you. Thank you so much, sir. Any other questions may I receive from the audience end?
Participants, you can ask your questions. We still have few minutes, so you can ask the question. Meanwhile, I'm sharing feedback form link in the chat box. I have shared feedback form link in the chat box. Meanwhile, you can fill up the form. Other participants can ask their queries. You can share your thoughts on the topic. The link is open till 12:10. It seems there are no queries now.
Yeah.
Thank you so much, ma'am.
Thank you. Thank you so much, ma'am, for such a nice opportunity. Thank you. Thank you, ma'am.
Thank you so much for joining us today. We are
Thank
really
you.
grateful for you
Thank
to
you.
do the webinar on healthcare affordability. And the discussion was very informative and eye-opening. I want to extend a special thank you to
Thank
ma'am.
you so much, ma'am.
Thank you. Thank you.
I, with your permission, can I leave the meeting, ma'am?
Yes, yes.
Thank you.
Good night. Thank you. Participants, uh, I have shared feedback from link in the chat box. And I request everyone to fill up the feedback form. Link will remain open till 12:10. Only those participants who fill up the feedback form will receive the participation certificate.